Hello and welcome to another Rush Generations Health Education Lecture. Rush Generations and our staff is delighted to be your source of information, resources, health promotion programs, all of those that help maximize your well-being and good health as you age. Today is Wednesday, March 5th. I'm Grisel Rodriguez Morales, Rush Generations Program Director, and I'll be your moderator for today's lecture, Colorectal Cancer. Before I present to you the wonderful speaker that we have joining us today, I'd like to first thank our producer, Hannah Weitzman. Hannah has not only made possible today's lecture, but she also will be helping manage the chat and other key aspects so that we all can have a great discussion about colorectal cancer, including the risk factors, prevention, and management. As always, we are live streaming this lecture via our YouTube channel using the platform Zoom, which allows us to host a good number of people who regularly join us via phone. We are always so pleased that you join us. Now, for those of you on YouTube, we ask that you please use the chat function to ask questions or to add to the discussion throughout the lecture. We will make sure that your comments and your questions make it to today's presenter. And for those of you listening to the discussion via phone or via audio only, please know that you'll also have an opportunity at the end of the presentation to unmute your audio so that you can ask your questions. We'd like to remind you that all the information offered here is for general informational purposes only, and to always seek additional professional advice for situations that are very specific to you and to your needs. Okay, so we'll introduce now our speaker. We have today with us Dr. Mina Sadabs, who is a medical oncologist who specializes in treating gastrointestinal cancers at the Rush MD Anderson Cancer Center here in Chicago. Her clinical interests include pancreaticobiliary cancers, colorectal cancers, gastroesophageal cancers, as well as precision medicine. She is the clinical director for the precision medicine program at Rush and leads the molecular tumor board. Her research interests include early onset colon cancer, pancreaticobiliary cancers, gastroesophageal cancers, racial disparities, and molecular profiling. She has been a long-standing member of the American Society of Clinical Oncology since she was a trainee participating in several different committees and programs that are sponsored by that professional association. Dr. Sadabs, it's such a delight to have you with us today. Welcome.
Thank you so much for that wonderful welcome. I'm very excited to be here. Thanks for inviting me. As you mentioned, I do treat all gastrointestinal cancers, but colorectal cancer holds a place that's near and dear to my heart, so I'm very excited to present on this topic today.
It's our pleasure to have you.
Let me just share my screen.
Wonderful.
Okay. Can you guys see that okay?
Yes.
Okay, perfect. All right, so going through a brief agenda for what we'll talk about today. So we're going to start off with epidemiology. We will then go into talking about risk factors, screening, and prevention. And we'll touch on diagnosis and just briefly clinical management, and then address any questions. All right, so first and foremost, epidemiology. So over 150,000 cases of colorectal cancer have been diagnosed annually, with over 53,000 deaths. That makes colorectal cancer the second most common cause of cancer-related deaths in the United States. Colorectal cancer has also caught the public's eye with a lot of notable figures being diagnosed with colorectal cancer as well. Ruth Bader Ginsburg suffered with pancreas cancer at the time of her death. However, she was previously diagnosed with early stage colon cancer. And then, of course, Chadwick Boseman, who unfortunately passed away from colon cancer as well. So in the US, the lifetime incidence of colorectal cancer in a patient who is at average risk is about 4%. Colorectal cancer incidence tends to be higher in males as compared to their female counterparts, as well as in Black Americans, Native Americans, and Alaskan Native individuals as compared to their white American counterparts. Overall, I will say, though, that we have actually seen declines in colorectal cancer incidence during the past decade, probably due to the widespread uptake of screening. However, interestingly enough, declining incidence is confined to those aged 65 and older. Since 2011, rates have been stable in patients who are between the ages of about 55 to 64, yet we find that these rates are increasing by about 1 to 2% per year in those younger than 55. These incidence trends are rapidly shifting the patient population that we see to a much younger one. Overall mortality rates similarly have dropped by 56% from 1970 to 2021 due to reductions in incidence, earlier detection through screening, and improvements in treatment. During the past decade, the death rate declined by 1.8% per year in both men and women. However, similar to incidence, this progress is confined to our older adults. Mortality rates in those under 55 have increased by about 1% per year since the mid-2000s. There has also, unfortunately, been a trend towards more advanced disease. So incidence rates for advanced disease have increased by about 3% annually in people younger than 50 and 0.5 to 2% annually in those aged 50 to 64 since around 2010. So that brings me to point 3 here, which is the global epidemiological trend towards early onset colorectal cancer. And that is, as you can see here, defined by patients who are younger than 50 years of age. Oh, I'm sorry. Just roll back here. I apologize for that. Recent data from Cancer Statistics 2023 reported out that colorectal cancer has become the deadliest cancer in men aged 20 to 49 years. Now, we don't really have any definitive risk factors to explain why we are seeing this rising incidence. And in fact, we can't necessarily always blame it on hereditary risk because about 80% of these cases are sporadic in nature. What we do tend to see as a possible etiology is diagnosis-related delays, as well as, given the young population, we do see challenges in regards to psychosocial factors, financial concerns, and of course, fertility preservation is something that we also deal with in that population. The most common sites of spread for colorectal cancer include the regional lymph nodes, the liver, the lungs, and the peritoneum, which is basically the abdominal cavity. Colorectal cancer tends to spread either the lymph node system or the blood system. And although brain mets are exceedingly uncommon, as patients receive more systemic therapy and stay alive several years longer now after their diagnosis of metastatic cancer, there has been an increase that we are now seeing in both bone and brain mets. So something to keep in mind as well. All right, so now touching on clinical signs and symptoms. And early detection, again, is key. So it is important to be cognizant of any of these symptoms. Patients with colorectal cancer can really present in many different ways. We can have patients who are completely asymptomatic and they are diagnosed incidentally when they're getting imaging for a different purpose. Or it could be that they're undergoing just routine surveillance with a colonoscopy and they are incidentally found to have a lesion on that exam. Then, of course, we have our patients who are symptomatic and display any of these signs listed here. And then we have patients who present more urgently in the setting of obstruction, perforation, or GI bleeds. So again, kind of touching on the points that I haven't mentioned so far. So of course, rectal bleeding. abdominal pain or cramping. Sometimes we don't necessarily clinically see bleeding, but on blood work, we can see that the hemoglobin is low, reflecting anemia, which can present with symptoms such as weakness, fatigue, or shortness of breath. Patients can present with changes in bowel habits. So that can include changes in the stool caliber, changes in the stool shape, and changes in stool frequency. This one is not as common, but sometimes we can see abdominal distension or nausea and vomiting. These two symptoms tend to be more indicative of a possible obstruction, so something to be aware of. Weight loss, and I should specify unintentional weight loss, loss of appetite, and tenesmus, which is basically the urge to defecate without necessarily completely emptying. So patients who are symptomatic at diagnosis typically tend to have more advanced disease than patients who present asymptomatically or found incidentally. Obstruction and or perforation, as I had mentioned before, although they're uncommon, they do carry a poor prognosis. Now, the first 2 points that I mentioned, or rather the first point and the bottom one on the left-hand side, so rectal bleeding in combination with a change in bowel habits really is the most common combination of symptoms that we see. Less common, as I mentioned, abdominal distension, nausea, vomiting, but again, could be indicators of obstruction. And sometimes we find that symptoms can also be based on the tumor location. So of course, our colon is very lengthy, and we tend to separate tumors, whether they're located on the right side of the colon versus the left side of the colon. So for example, changes in bowel habits tend to be more common for patients with left-sided tumors than right-sided tumors. Bright red blood per rectum, or hematochezia, is more often caused by rectosigmoid cancer. So again, left-sided tumors more so than right. As far as iron deficiency anemia, we tend to see that more so with right-sided cancers. Abdominal pain can be pretty nonspecific, so we can see that with either side. And then rectal cancers more so can present with tenesmus, rectal pain, and diminished caliber of stools. So now we'll touch on some risk factors as well as some protective factors. So there are many possible reasons why we are seeing colorectal cancer in general, but also why we're seeing this rising incidence in our younger population, but we don't really have any definitive answers just yet. So the way I like to divide it is modifiable risk factors as well as non-modifiable risk factors. So within modifiable risks, we of course have poor diet, and poor diet typically includes a high consumption of red or processed meats, low calcium, low whole grain and or fiber intake as well. Sedentary lifestyles. Poor diet also kind of goes hand in hand, and again, sedentary lifestyle as well goes hand in hand with increasing rates of obesity, metabolic syndrome, and diabetes. Smoking can be a risk factor, stress, alcohol, and it's usually excessive alcohol use that tends to be a risk, as well as antibiotic use, and we'll delve a little bit more into that later. In terms of non-modifiable risks, we of course see, just medical conditions that cause generalized inflammation, right? So inflammatory bowel disease, or for example, cystic fibrosis patients, especially those who have undergone transplant, lung transplant, and tend to be immunocompromised, they can also see increased risks. Alterations in the gut microbiome, and that's kind of where I was leading with the antibiotic use. And we'll talk more about the gut microbiome on later slides. Environmental and occupational exposures, personal or family history of colorectal cancer or adenomatous polyps, and hereditary syndromes. And I forgot to mention when I was going over modifiable risks, so smoking is not only a risk factor for colorectal cancer in and of itself, but it's also a risk factor for all types of colonic polyps. And then, as I mentioned, when we first came to this slide, we do have many possible reasons, but no definitive answers. And so there is this double hit theory that it's likely multifactorial, right? It's likely a combination of genetic alterations that elevate our susceptibility to develop colorectal cancer, and then that combined with the environmental conditions that we're exposed to. All right, so hereditary cancer syndromes, I did want to touch on this a little bit. So though inherited susceptibility results in the most striking increases in risk, the majority of colorectal cancers, as I mentioned before, do tend to be sporadic rather than familial or inherited. Our two most common hereditary cancer syndromes include familial adenomatous polyposis, FAP, and Lynch. Lynch is the most common. But together, these two hereditary syndromes only account for about 5% of colorectal cancer cases in total. In the United States, if we look specifically at our young adult cancers, it can account for rather up to 35% of young adult cancers with known hereditary syndromes. But again, the remainder of why we're seeing younger folks develop colorectal cancers is still unknown. So I'm not going to go too much into detail on this, but again, I just wanted to say that Lynch syndrome is the most common hereditary colorectal cancer syndrome. It is inherited in an autosomal dominant fashion and accounts alone for approximately 3% of all colorectal cancers. It is typically suspected on the basis of a strong family history of colorectal cancer, endometrial cancer, and other cancers. So when I say other cancers, again, colorectal cancer and endometrial are the two big ones that we see with Lynch syndrome, but we can certainly see other primary sites, including ovary, stomach, small bowel, liver, bile duct, brain, kidney, ureter, as well as possibly breast and or prostate. So it can consist of many different cancers. All right, so this slide really, again, not going to go too much into detail on this, but this is just to say that there are many other less common hereditary cancer syndromes that we do need to take into account as well, but these are not as commonly seen. So the gut microbiome is an area that has really been in the spotlight with research as of late. And the thought is that maybe the bacteria that is present in our gut is responsible for developing these colorectal cancers. So basically what we call the gut microbiome is the totality of environmental exposures during a person's lifetime that can influence basically the bacteria, the good and the bad, that we see in the gut. And this could potentially be a factor in the pathogenesis or the mechanism of colorectal cancer developing. So there have been studies, and again, ongoing studies as well, looking into, especially in our older population as well as our younger population, what kind of bacteria are we tending to see more of in patients with cancer as opposed to the general population? And so in studies that particularly looked at patients who are older than 60 years of age, they did see an abundance of Bacteroides, Peptostreptococcus, Streptococcus, Prevotella, as well as E. coli have been, again, they found that all of these have kind of been linked to the risk of developing colorectal cancer, while Lactobacillus and Bifidobacterium may reduce the risk. Again, given that the majority of patients in these studies were older than 60 years, it's kind of hard to extrapolate the same findings to our younger population. There were some early investigations that did identify Fusobacterium and some of these other bacteria as specific to early onset colorectal cancer. But again, a very hot area of ongoing research to see if this is an area where we could intervene as a preventative measure to prevent these cancers from developing in the first place. All right, so to touch on prevention here. So the things that we can do to try to reduce our risk of developing colorectal cancer include regular physical activity, limiting our alcohol intake, reducing red meats, fatty meats, as well as avoiding processed foods, smoking cessation, And of course, a higher intake of fruits, vegetables, and fiber, particularly from whole grains. There is a lot of data out there, a lot of ongoing studies, but I will say sometimes it's hard to kind of tease out what is necessarily good or what has been proven. So I will say, you know, I did encounter data on vitamin D, tea, onions, coffee, fish, garlic, magnesium. But again, the data on all of those things has really been conflicting to kind of recommend one way or the other. There was mention as well in the literature about hormone replacement therapy in postmenopausal women, especially combination estrogen and progestin therapy, potentially being, or rather reducing the risk of colorectal cancer. But what was interesting was that they did find a lower diagnosis rate of colorectal cancer in the group that was taking hormone replacement therapy, but actually found that those who were diagnosed at more advanced stages, sorry. So again, just based on this paradox, there's a thought that it could be explained by a systematic diagnostic delay in females receiving combined estrogen and progestin therapy, or it could just suggest that hormone replacement therapy actually affects the biology of colorectal cancer. But even prior to this data coming about, postmenopausal hormone therapy was really not recommended for chemoprevention because of the associated long-term risks of therapy. So there's definitely a lot of side effects with hormone replacement therapy that kind of outweigh any sort of benefit that we would see. All right, I did want to touch on aspirin because I know this one has come up a lot as well. There was actually a study that was reported out. It's called the CAP3 trial. Now, this was specifically designed to look at the optimal dose of aspirin for prevention in individuals with Lynch. So that is the most common hereditary colorectal cancer syndrome that we see. But I will say, given the broad age range of the study, there may be some insight into the optimal age of initiation. There was, it did show that use over several years appeared to result in risk reduction that then becomes evident 5 to 10 years after commencing an aspirin regimen. So although limited, the data supporting a possible benefit for early onset colorectal cancer may warrant discussion of an aspirin regimen at earlier ages, especially for patients who initiate screening between ages 45 to 50. The concern with widespread implementation of aspirin use, however, despite these established potential benefits, stems from the increased risk of bleeding. So again, kind of weighing risk versus benefit for these folks. More recently, there has been data looking at aspirin use in the adjuvant setting, meaning after folks with localized colon cancer undergo curative intent surgery, and they either get chemotherapy afterwards or not, depending on their stage. They did find that if these patients had a certain PIK3CA mutation, that they could potentially benefit from aspirin use following surgery to help reduce the risk of the cancer returning. So just things to keep in mind. So screening. Whoops, let me go back. Okay. So screening with the new updated guidelines as of 2021, colorectal cancer screening should now start at age 45. Screening is recommended from age 45 to 75, and the decision to screen after the age of 75 really should just be made on an individual basis. It is important to speak with your healthcare provider about early screening if any risk factors are present. So that could be any of the symptoms that we discussed previously, if there are any known genetic conditions in the family or if there's family history of cancer. And then, of course, following healthy lifestyle choices. So there are many different tools or modalities that we could use when we go about colorectal cancer screening, but of course, the most common is a colonoscopy. I will go over some of these other modalities as well. FIT testing is pretty popular, so we'll kind of go over the differences between all of these modalities. So overall, I would say that, and this is a big table, sorry if the font here is small, but this is a nice table that kind of summarizes the different modalities and the pros and cons between each of those things. So again, in terms of which test patients tend to go with, really, I think is largely driven by patient preference, as well as individual risks, right? So if someone has a lot of family history of colon cancer, then they probably want to opt for a colonoscopy rather than a non-invasive test like a FIT test. And then, of course, the cost of the testing varies from modality to modality. So we'll talk about that. So what exactly is a FIT test? So a FIT test basically stands for a fecal immunochemical test, and it basically detects blood in the stool. And then we have the second one here on the graph. So that is the DNA stool test, or basically a FIT DNA screening, if you will. It combines the FIT test, so it's detecting for blood, but at the same time combining that with the DNA analysis of the stool sample. So it looks for any abnormal DNA markers that could indicate the presence of colorectal cancer or polyps. So it basically makes that FIT test, by adding the DNA component to it, you're making it more sensitive in detecting early signs of cancer than a standard FIT test alone. However, FIT DNA tests tend to be more expensive, and they do run the risk of having a higher false positive rate. So if we look at the FIT test alone without the DNA component, it has about a 73.8% sensitivity for cancer detection, suggesting that most of the cancer sensitivity of the combination test is not really due to the genetic markers, but the blood alone has a fairly decent sensitivity in and of itself. But again, when you look at polyp testing, right, the FIT test alone has about a 30% advanced adenoma detection. And there's also concern over detecting serrated lesions, which is just a type of polyp or a type of lesion that the gastrointestinal doctors could detect when they go in and do a scope. With the FIT testing, the frequency of that is recommended to be done yearly, whereas a FIT DNA test would be done every 3 years. So the thought is that, you know, with the sensitivity of the FIT test being fairly decent in and of itself, one way to kind of avoid the increased cost of the FIT DNA would just be to get a yearly FIT test. And the thought is that the cumulative sensitivity then would be pretty equivalent to a FIT DNA test for cancer screening. So FIT testing is listed as a first-tier designation for colorectal cancer screening, along with colonoscopy. FIT DNA test is considered a second-tier option. But again, the frequency on that would be every 3 years. So now when we compare the FIT DNA test, or the FIT test rather, to the colonoscopy, what does that look like, right? So if we take the FIT DNA test, it's about 92% sensitive for finding cancers, which is pretty equivalent to a colonoscopy. The sensitivity at detecting cancer with a colonoscopy is about 95%. And the reason that that's not 100% is, you know, sometimes there can be folds in the intestine that could then hide a potential lesion. And of course, to some degree, it's operator dependent as well. But in terms of the main difference between FIT and colonoscopy, or FIT DNA and colonoscopy, is in terms of polyp detection. So the comparison there is pretty different. So with the FIT fecal DNA test, the detection rate for high-grade dysplasia or high-grade precancerous cells is about 62%. But when we look at the detection rate for detecting any sort of polyp, that then falls down to 42%. Whereas a colonoscopy, the sensitivity for finding a polyp, even a polyp that's smaller than 6 millimeters, is pretty high. It's up to 75 to 93%. So a patient, for example, with known colon polyps would want to go the route of a colonoscopy rather than a FIT test. So again, a little individual specific. And then, as I said, you know, it is dependent on risk, right? So depending on family history, personal risks, that sort of thing, you can come to the decision with your primary care doctor or whoever it is in terms of what test might be the best option for you to pursue. What I do want to highlight as well here, obviously there are other tests that are mentioned, and we can briefly go over those too. So a flexible sigmoidoscopy, which is listed under the colonoscopy, that is basically an abbreviated scope, if you will. So you are primarily looking at the left side of the colon. So it is technically less invasive because you're not going as far into the bowel. But then again, you know, you do run the risk of not detecting any lesions there on the right side of the colon. Both the colonoscopy and a FlexSig do require preparation or enema preparation, and they do run risks of obviously an invasive procedure. A flexible sigmoidoscopy is a little bit less invasive, as we said, as compared to a colonoscopy. With a CT colonography, it is less invasive, but it still requires prep. And of course, with it not being invasive, we have a lower risk of complications. But again, the main thing that I wanted to stress here is that a colonoscopy really is the gold standard, right? It is the main way that we can intervene. So if your gastroenterologist goes in and sees a polyp, a colonoscopy is the only way that we can then retrieve or remove the polyp and send it off for testing. So if there's concern for a polyp or a cancer on any of these other modalities, other than a direct scope, there's no way to intervene. So if there's a positive fit or a positive fit DNA, that automatically requires you to then get a colonoscopy. So something to keep in mind. All right. The next slide is just going over screening in special populations. So as I mentioned before, screening across the board starts at the age of 45. But of course, that needs to be adjusted based on your individual risks. So earlier initiation of screening should take place for patients with major hereditary colorectal cancer syndromes, and that's dependent on what specific syndrome we might be talking about. Patients with inflammatory bowel disease, and any relevant personal or family history. And that, I should also have put on here, patients who have a history of abdominal radiation also have an increased risk for colorectal cancer as well. So their initiation for screening might start sooner. For example, if I see a patient in clinic who has young children and they are diagnosed, let's say at the age of 40 with colon cancer, colorectal cancer, then I often advise them in clinic that their children should start screening 10 years prior to their diagnosis. So if they're diagnosed at the age of 40, their children should then start screening with a colonoscopy at the age of 30. All right, so what is the initial workup when patients come in with concerns for colon cancer? So we typically get blood work. And that's basically looking at blood counts, making sure, especially if patients are having bleeding, that their hemoglobin or their red blood cells are at a sufficient level. We are looking at electrolytes, kidney function, liver function with our basic blood work. And then we also tie in a marker called a CEA. And a CEA is basically a lab value. It is a protein or a cancer marker, if you will, in colorectal cancer, but it is a protein that can be expressed by cancer cells. Not all patients have an elevated CEA at diagnosis, but it is something that we check and we tend to follow throughout a patient's throughout a patient's journey with colorectal cancer. We look at overall pattern recognition rather than individual values. And in general, if we see a rise or an increase in that value, that might trigger us to get scans done sooner for concerns of progression of disease and such, whereas a trend in the opposite direction would be more assuring in terms of a positive treatment response. Of course, all of these patients should have already undergone a colonoscopy at the time of diagnosis with a biopsy. And then for all of our patients, the most important question, right, is what is the extent of the cancer? So we want to know, is that cancer confined to the colon, or is there concern for spread elsewhere to the body? And we typically get that information by doing full body scans. So in this case, we would do CT scans of the chest, abdomen, and pelvis. Once a cancer diagnosis is confirmed, we typically will refer, and again, it's all dependent on the extent of the cancer, but we typically get multiple teams involved, including colorectal surgery, medical oncology, genetic counseling, especially when we're dealing with our younger patients or those younger than 50, supportive oncology, fertility preservation, again, for our folks who are younger. But again, multiple departments to be looped in. All right, so I just wanted to put this in here, and again, not delving too much into detail on this, but just wanted to go over and a brief summary of how we manage colorectal cancer. So as I said, it's all dependent on the extent of the cancer, right? So if we're dealing with a localized colon cancer, patients will typically undergo surgery first, and the intent here is to cure the cancer. So we do surgery first, and then depending on the stage of the cancer, we decide on whether folks need to get adjuvant or post-op chemotherapy. And that's all dependent on, again, the stage of the cancer and different things that our pathologists look at under the microscope. So big ones are if there is lymph node involvement, if there, again, was any sort of concern for perforation or obstruction at time of diagnosis, the depth of invasion of the tumor. So again, multiple things that we take into consideration when we make that decision about whether chemotherapy is warranted or not. Localized rectal cancer is similar, however, it incorporates radiation. So for folks with localized disease, we usually do a combination of chemotherapy and radiation. And the radiation is more so to help reduce the risk of the cancer coming back locally or in that area in the rectum. And then we follow that up with chemotherapy and potential surgery afterwards. The IV chemotherapy portion there is more so to decrease the risk of the cancer returning elsewhere in the body. And then we come down to metastatic disease. So whether it's metastatic colon or metastatic rectal, we treat it pretty similarly in terms of chemotherapy regimens. But it also depends on the extent of how much the cancer has spread. So in certain cases where we're only seeing a few spots to say the lung or the liver, then we could consider, going after those individual spots and still attempting at achieving a cure for the patient. So that's something to keep in mind. If it is a larger tumor burden, meaning we're seeing a lot of spots, in which case we can't necessarily go after each and every one, then we typically are looking at chemotherapy to help increase both quality and quantity of life. I always say it's important to get molecular testing. And again, precision medicine is a big part of what I do, but I always encourage folks to get molecular testing or mutation testing early on. It does take about 3 to 4 weeks to get these test results back. So it's helpful to have them on hand earlier on, just to see if that, will affect treatment decisions for the patient and or help to line up clinical trials. So that is all I had. Thank you guys so much. Hopefully that was all helpful information, but I'm happy to take any questions.
Thank you. Oh my gosh. I was holding my breath, I think, presentation. Thank you so much for all this information. We have a few questions already, but want to start with this one in terms of hereditary family history. What happens when someone is insured, they know there is some type of cancer or some type of abdominal cancer, but not sure if the diagnosis was indeed colorectal cancer. What are some of the recommendations in that case?
That's a really good question. I would say I would ask a little bit more detail. So if we knew perhaps at what age that family member was diagnosed, was it a young diagnosis of cancer? Was it an older diagnosis of cancer? I would use that additional information. And then again, at any point, even if we're unsure and patients are interested in genetic counseling, we can always refer patients to genetic counseling. They can have a very similar conversation with the genetic counselor. And again, as long as insurance covers it, they can usually get testing done. And even if insurance doesn't cover it, you can still get the testing done and pay out of pocket. But if there's any sort of question or concern, and you do have a pretty significant family history, but you just don't know the details, I would say it's definitely a good idea to still get the testing done.
Great. So the genetic counseling is done within the clinic, the oncologist?
So it is done at Rush, not necessarily within our clinic, but they do offer both virtual and in-person visits for patients. And then if patients are interested in getting the testing done, it would be blood work. And it usually takes about 3 to 4 weeks to get the results back. And only if there is a concern for hereditary cancer syndrome would their children and their siblings then be encouraged to get tested as well. But if there's no particular findings that are concerning, then the testing would stop with them.
Interesting. Okay. In terms of the higher intake of fruits and vegetables, which is one of the preventive methods, that indicates the higher intake of fiber. And I'm sorry, I'm gonna give the callers a chance to ask question. I skipped that part. My apologies for our callers. Um, how many grams or pounds of veggie and fruits are recommended each day?
Yeah, you said how many pounds?
Grams or pounds?
That's a good question. I can certainly touch base with our nutritionist and get you a specific quantity on that. I don't know a specific quantity off the top of my head, but I always say with each meal, right? Patients often ask us are there any restrictions with my diet? Is there anything that I should make sure that I include? So what we always say is I am not keen on removing anything strictly from anyone's diet. I always say a well-rounded meal is a good meal, but also the key is making sure that you're incorporating protein. And then with the well-rounded meal, you're getting, a share of fruits, veggies, all of the things. But protein especially is key to prevent any sort of deconditioning. And we want to make sure, especially when patients are on chemotherapy, for example, we want to make sure that they're strong enough to handle treatment and that we're not taking away from quality of life. So nutrition is definitely key for all of that.
It always is. I mean, it's one of the modifiable risk factors, as you said. So some things that are under our control. Okay, let me pause for a second to invite our callers if they would like to unmute. Star 66. I always doubt if that's the case, but I think it's star 60. Oh, star 6. Sorry, star 6. You can ask. That will unmute your audio, and you can ask a question. And if not, then we'll continue. There was also a question about test kit, home test kits. And I think it came up around the time you were discussing the fecal testing.
Yep.
So how often should a 77-year-old use the at-home test kit?
Okay. So again, I mean, we typically recommend general screening for folks with an average risk from 45 to 75. And then from 76 onwards, it's based on individual risks. So I would say it's based on multiple things, not only individual risk, but any other comorbidities that that patient has, performance status, that sort of thing. So I would have that discussion with your primary care provider and see if it makes sense to continue doing the testing. If they agree that it makes sense to continue doing the testing, then I would continue to do the fit testing. That would be yearly.
Excellent. Okay. I always like when we're discussing especially prevention or things like that. For example, the poor diet, if we attend to that, then we can have better prognosis or outcomes, or stress as well, paying attention to that, stop smoking. Now, you included in those things that we can change or the modifiable factors, antibiotic use.
Yes.
I mean, if we need to take antibiotic, is that where the gut when we have to attend more to the gut microbiome?
Yeah, so the antibiotic use comes up because of the thought of how it's affecting our gut microbiome. And again, it's hard to say anything definitively at this point because, like I said, this is a very hot topic in current research. And so hopefully we'll know more in the coming years. But that is something that definitely that we do know affects our gut microbiome. We just don't know if it affects it in a positive way or a negative way.
And that's where you have probably afterwards you need to pay more attention about what you eat and having the same way that you have 10 days of antibiotics, maybe the following 10 days be more tender to your diet. And okay, there was a question about the symptoms. The symptoms, I think you mentioned pain, nausea, abdominal pain, weight loss of appetite. And that can happen with almost, like on a daily basis. So if there's one or two that should raise an immediate red flag for us, or we just anything?
Great question. So unfortunately, a lot of symptoms of cancer are very non-specific. And so that is oftentimes the reason why, patients don't necessarily seek medical attention sooner. And unfortunately, why we do kind of catch things at a later stage. But that being said, I think with colorectal cancer, the most common symptoms that we do see that should raise a red flag are blood in the stool and any changes in the bowel movements, right? So whether that's a change in the caliber of the stool, a change in the shape of the stool, a change in the frequency that you're going in combination, especially with blood in the stool, should definitely be a big red flag.
Any sudden changes or changes at all? Okay, thank you, Hannah. The home test that the person was referring to is Cologuard. Cologuard.
Is Cologuard?
Yes, yes.
Okay.
I think I've seen.
Oh.
We're not making an announcement here, people, but that was the name that was given to us. Yeah, apparently that's the home test kit. Any question, any input on the Cologuard? Or I think, as you said, maybe check with your doctor.
It'll be the same. Yep.
All right. Thank you so much.
At 76, we want to, it's on a case-by-case basis if it makes sense to continue.
Okay. And can you say a little bit more? What's the inflammatory bowel disease?
Inflammatory bowel disease would include Crohn's disease and ulcerative colitis. So,
Crohn's.
right, and we often see inflammatory bowel disease in a lot of our younger patients. So, again, patients with ulcerative colitis or Crohn's disease, depending on the extent of the inflammation in their intestines, can, alter their risk. So oftentimes these patients are at an increased risk and should start screening sooner.
Excellent. Okay. Thank you, Hannah. Are there any holistic approaches to managing symptoms that you could recommend? Holistic approaches.
So it's hard for me to attest to any sort of holistic remedies because, again, none of these remedies are FDA regulated. So we just don't know the purity of these components.
Mm-hmm.
And oftentimes we have to be very wary about how it affects our kidneys and our liver. And so, I am not opposed to our patients combining holistic, remedies with their chemotherapy. And if that's the case, we often, we'll make sure that it's open, two-sided communication. So I always tell patients, let me know what you plan on taking. That way I can run it by our pharmacy team and just make sure that there are no safety concerns or drug-drug interactions. But, if patients want to pursue holistic remedies, then we certainly work with them so that we can accommodate that. If I have had patients who have also asked about like medical marijuana, and I have found, and I have seen that patients have seen improved nausea, improved appetite, as well as sometimes improved pain with medical marijuana. So again, that is something that our palliative medicine team can help with. But yeah, those are the more common ones. But if it's on a case-by-case basis in terms of specific holistic remedies, then again, I usually just have them let me know so we can make sure that there's no safety concerns with any treatment that we're giving them.
Oh, excellent. The fecal test, is this done when the blood in stool is noticed or suspected?
So it is done, so I think they're referring to the FIT test. So the FIT test basically is a at-home stool test. And the specimen is wiped on the card and it basically detects if there's any blood in the sample. So this wouldn't necessarily be for blood that you can personally see in the toilet, but this would be detecting any sort of microscopic blood in the stool that we can't necessarily appreciate.
Got it. And I think that the last question is around the colonoscopy or the colonoscopy, you said that is the gold standard. I imagine it's because it's more easy to see. I don't know if I should say more easy, but it's easy to see the
Exactly.
polyps.
Yes, so with the colonoscopy, you have better detection of polyps. It's direct visualization. And on top of that, it allows for intervention, unlike the other modalities.
To be removed and then to find for to send it to the lab. However, a lot of people then hate the preparation. So any advancements that have changed the preparation or any words around that?
Sorry, I didn't hear your question.
Or any recommendations about how to, are there any new ways to prepare for that colonoscopy or?
Yeah, so I have heard the prep can be pretty brutal. What I will say is that it helps if you don't eat as much the day that you're doing the prep. So what patients will do, or what we typically recommend, is 2 days prior, tell them to eat very bland foods. And then the day of, just kind of switch to a liquid diet for the whole day while you are doing your prep. That way there's less to come out before you clear. So you don't necessarily always need to finish the entirety of the prep, because oftentimes the biggest issue is the volume of the prep, and you don't necessarily need to finish it. It's just we need to make sure that the stool is clearing. So when when we start to see kind of a lightish yellow output, then we know that we've pretty much cleared out the entire bowel.
Good, good, good. And there are some things that are not as pleasant, but that we need to do in order for us to continue being healthy and age well. So
Yes,
I hope that mindset helps.
absolutely.
Well, thank you so much, Dr. Sadabt. It was a pleasure and great information for our Rush Generations members. As you know, this will continue to be in our YouTube channel so that you can share this great information with family, friends, and maybe start some great discussions.
Thank you so much for having me.
Thank you. Okay, so let's now tell you about the upcoming programs that, oops, sorry, I clicked the wrong button. The upcoming programs that we have for you, starting with Take Charge of Your Health, which is one of the evidence-based programs that we offer at Rush Generations. This one is a 6-week workshop for people with ongoing health conditions. In this one, you can learn how to build skills to gain confidence, to better manage your health, and therefore lead a more active life. Over the course of 6 weeks, we discuss goal setting, nutrition, physical activity, medication and pain management, effective communication. Effective communication is important, not only with friends, but also with providers, and strategies for working with healthcare professionals. The next one that we have starting on April 8th will be held in person at the Rush campus, the main Rush campus. It's going to be on Tuesday, starting April 8th through May 13th, 9:30 to 12. It's a 2.5 hour that go by very, very quickly. We promise you. It's 2.5 hours of great information and learning from the facilitators as well as the participants. So give us a call if you would like to be part of this next workshop. 1-800-757-0202 is the number to call. Then we also have starting soon WRAP, which stands for Wellness Recovery Action Plan. It's a free program for adults to learn skills to get well and stay well and to make life more enjoyable. This workshop will teach participants to develop a daily wellness plan, discover simple and safe strategies, and create plans for responding to stress, negative thoughts, and challenging times. The group meets once per week for 6 weeks for 1.5 hours for 90 minutes. And the next workshop will be held also in person at the Rush campus on Monday, starting April 14th through June 9th. It's going to be in the afternoons, 1 p.m. to 3 p.m. We require that you please register So feel free to give us a call. The number again, 1-800-757-0202. Walk with this. Oh, and the weather is gonna be great when we start this weather with this workshop or these evidence-based programs. This is an enhanced walking program through the Arthritis Foundation, and participants meet 3 times a week at Garfield Park Conservatory, which is a great place, with a certified walk with this facilitator, and walk together at your own pace. So don't get discouraged if you think it's gonna be, you have to keep up with others. It's at your own pace. The walks can range anywhere from 10 to 45 minutes. And individuals living with arthritis, osteoporosis, chronic pain, and other conditions are encouraged to participate, although you don't have to have a health condition to participate. And you may want to bring a buddy, a friend, or a family member. Anyone who wants to connect with others and become more active is welcome to join. The program is going to meet in person at the Garfield Park, like I said, Garfield Park Conservatory, on Wednesdays, Thursdays, and Fridays, starting on April 30th. It should be warmer through June 6th, and it's, again, 90 minutes, 1 to 2:30 p.m. Give us a call, 1-800-757-0202. We also want to learn from you. We want to hear from you. Shulman Senior Voices aims to empower older adults to discuss what matters most to them as they age. So it is important for you to share what matters most to you with your physician, with your loved ones, and this is a great way to do it. So consider sharing your wisdom on why it is important for your healthcare team and your loved ones to know your health goals and your wishes and what matters most to you. So you can scan that QR code or visit us at that bit.ly. Record my story and record a video. All right. We hope to see you next time, March 19th at 1 p.m. As always. We are gonna have the Women's Health Roundtable. We have a great panel for that program. So we hope to see you then. In the meantime, if you would like more information about our programs or to connect with some of our clinicians, feel free to give us a call to 1-800-757-0202. Thank you so much and have a nice afternoon. Take care.